One of the more challenging documentation situations in EMS is when a patient refuses care or transport. Competent adult patients have the right to refuse treatment and/or transport, but with that right comes our responsibility to ensure the refusal is informed and properly documented. Many lawsuits against EMS providers stem from situations where a patient refused care and later something went wrong. Thus, handling and documenting refusals correctly is crucial both for patient safety and legal protection. When you encounter a patient who does not want to go to the hospital or is declining a certain treatment, you must follow a careful process and document it thoroughly. Best practices for documenting a refusal of care include assessing the patient's decision making capacity. Ensure the patient is alert, oriented, and not impaired by substances or illness to the point that they can't understand their situation. Document your assessment of their mental status and capacity, like patient alert and oriented X4, no slurred speech or confusion, able to understand questions. If the patient is not competent, they have altered mental status, a minor without guardian, etc., they legally can't refuse. In those cases, refusal may not be valid and you should follow your protocols. This is a complex area, involve medical control as needed. Next, explain the current situation and your recommendations in plain language. Make sure the patient understands what the evaluation found and what treatment or transport is advised. Use non technical terms. For example, your blood pressure is very high and we think you might be having signs of a stroke. We strongly recommend you go to the hospital for further tests and treatment. It's important the patient knows why you believe they should receive care. Document that you explain these findings and recommendations. You also need to explain the potential risks and consequences of refusing care or transport. This is absolutely critical. The patient needs to be informed of what could happen if they don't go with EMS. For instance, I informed the patient that without evaluation at a hospital, her condition could worsen and could even be life-threatening. Be specific about serious risks like disability or death, but only if those are realistic outcomes. Use a tone that is informative, not threatening, but make sure they truly grasp the severity. According to case law, just getting a signature isn't enough. The protection comes from proving you explain the risks of refusal and the patient understood. A helpful step is having the patient repeat the risks of refusing the treatment or transport back to you in their own words. This shows that they not only heard you, but comprehended what was said. Offer alternative solutions or interventions, and always offer to transport again. Sometimes patients refuse because they think they have no other option. You can clarify or offer help. For example, if cost is a concern, explain why transport is important for their health. If they prefer to see their doctor, advise them on doing so urgently. No matter what, always leave the door open. If you change your mind or feel worse, we can still take you to the ER now, or you can call 911 again. Document that you offered transport multiple times. Also, if appropriate, involve medical direction. Some protocols require you to consult a physician for high-risk refusals, which can sometimes convince the patient or at least shares the decision-making. If medical control is consulted, document the doctor's name and advice. Have a witness whenever possible and get all necessary signatures. Ideally, a neutral witness like a family member, friend, police officer, or even a second EMS crew member hears you explain the risks and sees the patient refuse. Have that person sign the refusal form as a witness to the discussion. The patient should sign a refusal of care form indicating they are declining care or transport after being informed of the risks. You, as the provider, also sign and include the date and time. If the patient refuses to sign the form, note that explicitly. Patient refused to sign refusal form, and definitely get a witness to sign that you explained and the patient refused to sign. This documentation shows that you didn't simply walk away, you went through a proper process. Provide aftercare instructions and document them. Tell the patient what to do if they change their mind or if certain symptoms occur. A common practice is to advise, if you feel worse or have any further concerns, do not hesitate to call 911 again. You might also recommend, please follow up with your doctor as soon as possible, or provide information about alternate care if appropriate. In some systems, you might even give them a copy of the refusal form or a written instruction sheet. Make sure to document that you told them to call back or seek care if things get worse. Document the entire encounter thoroughly in your narrative. In the PCR narrative section, write a detailed account of the refusal process, how the patient presented that you did a full assessment, what you found, how you explained the situation and risks, the patient's reasons for refusal, if they gave any, quotes from the patient, and the fact that they demonstrated understanding. Note the time the discussion happened and the outcome. This narrative will be your protection if the refusal is later questioned. It should clearly show that the patient was informed and that you fulfilled your duty to advise and care for them as much as they allowed. By following these steps, you fulfill both legal requirements and ethical obligations. Ethically, We want to respect patient autonomy, but also do no harm, which means making sure they aren't making an uninformed bad decision. Legally, a well documented refusal can defend you in court. Now, let's talk about the narrative portion of the PCR. This is the section where you tell the story of the call in detail. The narrative should be detailed, accurate, complete, and specific. While other parts of the PCR are often checkboxes or short fields like vital signs, times, the narrative is your opportunity to paint a fuller picture of the patient encounter in prose. A good narrative allows anyone reading the report to understand exactly what happened on the call, almost as if they were there. Here are key elements and best practices for a strong narrative. Include important details from start to finish. A detailed narrative will cover dispatch information, dispatched for 45-year-old male with chest pain, what you found on arrival, the patient's initial presentation, the assessment including significant positives and negatives, interventions performed, patient responses to those interventions, and the patient's status at transfer of care. It should complete any story that the checkboxes began. For example, you might have checked chest pain, but the narrative would explain patient in tripod position on arrival, skin cool and pale, stated, I have crushing pain in my chest. After administering aspirin and nitroglycerin, chest pain reduced from 8 out of 10 to a 2 out of 10. Anyone reading that can follow the logical flow and outcome. Be specific, not vague. Use specific descriptions rather than general ones. For example, instead of writing patient in pain, write patient complaining of sharp pain in lower right abdomen, 7 out of 10 in intensity. Instead of we gave meds, specify the medication name, dose, and route, administered 0.3 milligrams of epinephrine intramuscularly in the left lateral thigh. If you immobilize the patient, describe how secured to backboard with C-collar in place, head blocks, and straps. Specifics make the report credible and useful. Document any consultations or orders from medical control. If you contact a physician for guidance, include the time and the doctor's name and exactly what orders were given or advice received. For example, spoke with Dr. Smith at ABC Hospital at 1520. Orders received to administer morphine 2 milligrams IV for pain and to divert to trauma center. Also document when you implement those orders. This is important because it shows you followed proper procedure for things that require a physician's permission, and it provides a record of that physician's involvement. Maintain accuracy and honesty. The narrative must be an accurate recounting. Do not add anything that didn't happen or leave out something important. Accuracy also means correct spelling of medical terms and patient identifiers, and correct use of medical terminology where appropriate. However, avoid jargon and slang. Write in full professional language so that anyone, including a lawyer or jury, potentially can understand. For instance, don't use texting abbreviations or undocumented acronyms in your narrative. It's okay to use common medical abbreviations that are universally known, like CPR, IV, or BP, but avoid things that might be ambiguous. Also, as mentioned before, do not include derogatory or speculative comments. Keep the tone professional and clinical. If this call involved a refusal of a treatment or transport or anything out of the ordinary, the narrative should thoroughly describe it. Remember that your narrative is often read in isolation. Sometimes hospital staff will skim the narrative to get a quick sense of the call beyond the vitals and checklist. Make it count. Ensure that reading your narrative alone would give a solid understanding of the patient's condition, what care was provided, and any outcomes or changes. A helpful mindset is to imagine describing the call to a colleague or writing it for a peer report. What would you absolutely want to mention? Also consider the legal and billing aspects. You want to include enough detail to justify all treatments and to defend your actions if scrutinized. For example, instead of just IV established, mention why IV established for medication access and fluid due to hypotension. This can show medical necessity. Finally, good narratives often follow one of the structured formats: chronological, SOAP, or DCHART, which we'll discuss next. Using a structure can ensure you don't forget any part of the story. Whether or not you consciously use an acronym format, make sure your narrative is organized and flows logically. A disorganized narrative can confuse the reader. An organized one, by contrast, demonstrates clear thinking and good patient care. Let's summarize some key elements of a properly written PCR, picking up from the previous slide and reinforcing a few additional points. They are complete and concise. Your report needs to be complete, meaning you have documented all relevant information and filled all sections, yet also concise, meaning it's to the point and not filled with unnecessary filler. It's a balance. Include everything important, but don't write a novel about irrelevant details. Timeliness. You should complete your PCR as soon as possible after the call, ideally immediately after transferring care, before you forget any details. A timely report is likely more accurate. Delayed reporting can lead to forgotten information or inaccuracies. Also, some systems have policies about how long you have to complete a PCR. Beyond policy, think of it this way. If you write the report promptly, it will contain richer detail, which is good for patient care if the hospital needs the info, and good for you if you ever need to recall the call later. Write the report in professional, clear language. Avoid slang entirely. For instance, don't write patient was plastered or we hauled the patient to ER. Instead, say patient appeared intoxicated, if based on evidence, or transported patient to hospital. No personal opinions or bias. As mentioned earlier, keep out any commentary that is not fact based. Do not include personal judgments about the patient, like the patient was rude or I think patient was faking it. If the patient's behavior is relevant, say they are belligerent or non-compliant, describe it factually. Patient continually yelled profanities and did not allow full assessment of abdomen. That's a fact of what happened. But don't add your interpretation like patient was just trying to get attention. That's an opinion and could be completely wrong and unfair. Similarly, do not guess at motives or make diagnoses that you can't confirm. Stick to what you saw, heard, and did. Avoid libelous statements. This ties in with opinions. Libel is written defamation. If you write something untrue and harmful about someone, that could be libel. For example, writing patient is an alcoholic without evidence or need could be considered defamatory and irrelevant to the call unless alcohol use is pertinent, in which case you'd still phrase it objectively like patient admits to drinking 750 milliliters of vodka daily. Write only what you would comfortably defend in court as a factual observation or necessary inference. If you wouldn't say it on the witness stand, don't write it. Professionalism in documentation protects you from slander libel issues. This sounds obvious, but it must be emphasized. Never falsify or fabricate information on a PCR. Every detail should be truthful. If you didn't take a set of vital signs, don't invent them to fill the blanks. If you didn't perform a treatment, don't chart it as done. It's better to acknowledge something not done than to lie. Falsifying a medical record is not just unethical, it's often illegal. Always double check for accuracy. Verify you typed the correct values. Check name spelling, medication dosages, etc. A small typo can lead to big misunderstandings. Before you finalize the report, take a moment to review it. This is your chance to catch mistakes or add something you forgot. Verify that times make sense chronologically, that all required fields are completed, that spelling and medical terminology are correct, and that the narrative is clear and complete. If you have a partner, both providers need to review the narrative before submission. In fact, each EMS provider on the call should sign off to affirm it's accurate. It's not uncommon for one crew member to remember a detail the other forgot, so collaborate. Ultimately, each of you is responsible for the content. When you sign the report, you are attesting it's accurate to your knowledge. If your service or region has a preferred narrative format or required elements, make sure you adhere to that. Consistency in documentation helps others read and find info quickly. Whether you use SOAP, DCHART, or chronological format, stick to it consistently so you don't miss things. Now we'll discuss different formats for writing the narrative. One common approach is to write the narrative in chronological order, essentially in a story format from the time of dispatch until the call is completed. This is often a straightforward way to document because you're basically recounting events in the sequence they happened. In a chronological narrative, you begin with how the call came in and what you found, then proceed step by step. For example, you might start, dispatched at 14:05 for an MVC, arrived on scene at 14:12 to find a two-vehicle collision, then describe finding the patient, assessment, interventions, transport, and finally transfer of care. You go through the timeline. Initial observations, patient exam, treatments given, with times noted perhaps in parentheses or as you go. Changes in patient condition, in route observations, and outcome at the hospital. This story-like format is intuitive for many providers and readers because it mirrors how the call unfolded in real life. It ensures that as you write, you naturally cover everything that happened in order. Chronological storytelling helps readers follow the progression. They can see cause and effect. Like patient given nitro, then blood pressure dropped. It's also helpful in court or QA reviews since the sequence of events is clearly laid out. While writing chronologically, be sure not to lose the structure of information. It's easy to maybe jump around if you recall something out of sequence, but try to integrate it smoothly, or go back and insert it in the proper order while editing. If something important happened out of the main sequence, say you discovered a med list later or a family gave you important info mid-transport, you can still include it where it makes sense. Chronological format is often taught first in EMT classes because it's conceptually simple. Just tell what happened as it happened. Many EMS providers use this format by default unless directed otherwise. It's perfectly acceptable and widely used. Another popular format for medical documentation, including EMS, is the SOAP method. SOAP is an acronym that stands for Subjective Objective Assessment Plan. It provides a structured way to organize information in your narrative by categories rather than pure chronology. Many other healthcare providers use SOAP notes, and EMS can use it as well for PCR narratives. Let's break down each component of SOAP and how it applies to an EMS call. Subjective. This is information obtained from the patient or others by talking, essentially the history of present illness and any statements or symptoms the patient reports, which cannot be directly observed or measured by you. In EMS terms, this includes the chief complaint, the history of how the current issue developed, and any pertinent medical history or medications or allergies the patient or bystanders provide verbally. It can also include bystander reports or scene descriptions that come anecdotally. Objective. This is what you observe or measure, the facts of the exam and scene. It includes vital signs, your physical exam findings, and observable indicators. Also, any treatments given up to that point and the patient's response can be noted, though some people put treatments in the plan section, there is some flexibility. For EMS, the objective part would include things like patient's appearance, vital signs, results of your head to toe exam. It's essentially the clinical findings. If writing SOAP style, you might list vitals and exam findings in a structured way under O. Assessment. In SOAP, assessment is basically your field diagnosis or clinical impression of the patient's problem, based on the subjective and objective info above. It can also include the patient's response to treatments so far. Some intermix this with plan. In an EMS PCR, you might phrase the assessment as, "What do you think is going on?" Some EPCRs have a drop-down for primary impression, but in narrative SOAP, you would articulate your conclusion. It might also include your rationale briefly, like signs and symptoms consistent with MI, although initial ECG non-diagnostic. Essentially, you are summing up the case. If the patient's condition changed with treatment, you might note that here too. Plan. The plan refers to what was done and what is planned to be done. In EMS, this equates to treatment provided and the transport decision, where you took the patient, or perhaps if you left them at scene in care of someone. In a SOAP narrative, you would list all interventions, note patient's response to each, if notable. Also include the transport mode and destination. Using SOAP format keeps your narrative organized by topic rather than strictly time. Some EMS providers like this because it clusters all history together, all exam findings together, etc., which can be easy for a reader to find specific info. In fact, many hospitals and clinics will immediately recognize a SOAP structure. As a paramedic or EMT, if you are comfortable with SOAP, it's a professional style to use. Ultimately, whether you use SOAP depends on your local protocol or personal preference. The key is to include all those components, subjective, objective, assessment, plan, in some form. SOAP just labels them clearly. If you do use SOAP, make sure you still include times for treatments in the plan if not obvious, and don't forget to record the outcome at destination. Done right, SOAP makes for a very clear, thorough PCR narrative. Another structured format commonly taught in EMS for writing narratives is the DCHART method. DCHART is an acronym, much like SOAP, but tailored for EMS call flow. It stands for Dispatch, Chief Complaint, History, Assessment RX, which is treatment, and Transport. Let's break down DCHART. Dispatch. Start by documenting the dispatch information. This sets the scene for your narrative. Include what you were dispatched to. This gives context right away about the situation you were heading into. You could also note if you were responding emergent or any relevant info dispatch gave. Chief complaint. Next, state the chief complaint as you find it. What is the main issue when you see the patient? It might be the same as dispatch or different. For instance, chief complaint was difficulty breathing and chest tightness. If the patient has multiple issues, you can list the primary one and secondary ones here. Essentially, this is the patient's reason for needing EMS from your assessment, ideally also reflecting their words. Put the chief complaint in quotes if it's verbatim, what they said. History. This refers to the history of present illness and/or injury and relevant past history. Describe what led up to the situation and any pertinent medical history. In the DCHART format, you combine both current event history and medical background here. For example, patient was watching TV when she developed sudden onset of shortness of breath and chest pressure 30 minutes prior to 911 call. She has a history of hypertension, COPD, and has had 2 previous heart attacks. Patient states she took 2 puffs of her inhaler prior to EMS arrival with no relief. This section should include medications taken, allergies, and any information gathered that is relevant. It's basically similar to the subjective part of SOAP, plus relevant past history. Also include any event history, like for trauma, how the injury happened. Assessment. Here you document your assessment findings, the physical exam and vital signs, your objective data. Include initial observations, level of consciousness, ABCs, head-to-toe exam findings, neurological exam if relevant, etc. Also include vital signs. You can list them as part of assessment. For example, assessment: patient found sitting upright, alert, in respiratory distress, skin pale and diaphoretic, breath sounds, bilateral rales and lower lobes, pulse ox 88% on room air, blood pressure is 160 over 100, heart rate of 105, sinus tach on monitor, respiratory rate of 28. No obvious injuries. Patient is anxious, speaking in 3 to 4 word sentences. That paints a clear picture of what you objectively found. RX here is a common shorthand for treatment. List all treatments provided and interventions in the order they were done. Include medications, both the dose and route and procedures like splinting, bleeding control, vascular access, etc., and the patient's response to each if notable. Essentially, this is like the plan in SOAP, but focusing on actions. Transport. Finally, document the transport details. This includes how the patient was moved to the ambulance, the mode of transport, any changes en route, and the transfer of care. If any issues happened during transport, like the patient got worse or any other notable events. Also include if family accompanied or if law enforcement followed, any relevant logistic details. DCHART is a nice mnemonic because it follows the typical EMS call progression: dispatch to chief, complaint to history to assessment to treatment to transport. Whether you choose SOAP or DCHART or just a well-formed chronological narrative, the goal is the same: to cover all aspects of the call in an organized manner. DCHART is simply one handy method to do so, tailored to EMS workflow. Use the format that you're most comfortable with or that your agency prefers. The key is completeness and clarity. Join me in the next lecture for more documentation information.